welcome from me. My name is Herman Groepenhoff. I'm part of medical affairs from Fire Medical, who are organizing these educational webinars. And I'm happy to introduce to you Dr. Sanja Stanojevic, who is one of the main authors of many GLI reference publications. And Dr. Sanja Stanojevic will explain more about the GLI reference values and about lower limit of normal, upper limit of normal, set scores, and why we should use them more, or why it is better to use this kind of outcome values from reference values than presented or predicted. Please, Dr. Sanja Stanojevic, start your webinar, and we will listen, and we will ask some. Hope there will be a lot of questions at the end of the webinar, and the webinar will hopefully only take 45 minutes when I stop speaking now and give the microphone to Sanja. Please
Wonderful.
go ahead.
Thanks, you, Herman. Let me just share my screen here. Okay. There we go. Okay, so thank you everyone for joining today, and I want to thank Fire for the invitation to present to you on this topic. Many of you will have heard of Global Lung Function Initiative, and hopefully today I'll explain the ABCs and what all these acronyms mean. So I do receive some funding from industry, and the GLI are sponsored by the European Respiratory Society Clinical Research Collaborative, but no direct conflicts. So the goals of today's session are first to introduce the GLI equations and highlight some of their strengths and why they're preferable to what we had previously. As any good academic, I will tell you all the things that are wrong with the GLI and where we have to improve. And in particular, as was indicated in the title, we're going to talk about the lower limit of normal and Z scores, and why the use of percent predicted is somewhat problematic when we're trying to interpret lung function. So let's start with just the basics. So why can't we interpret absolute measures of lung function? We measure spirometry, diffusion capacity in absolute volumes. So for FEV1, we measure liters, and yet we don't use our measured values to interpret. So there are certain instances where I think we should be using absolute values to interpret results. So for example, if we're looking at repeated measures in the same test occasion, you might be doing a trial of a particular treatment. If you're looking at short time intervals and you're more interested in the response of the individual, you're interested in how somebody's lung function is changing, again, due to a treatment or due to removing a potential exposure, then actually looking at the individual as their own comparison or their own control is far more informative. And in adults, if we were fortunate enough to have a baseline measure or somewhere where they start in their early 20s when they've reached that maximal lung growth, then actually, again, it's far more informative to compare an individual to their baseline than to just look at results relative to the population. And so there are lots of instances where interpreting and using the absolute measures that we measure are quite informative. But the challenge is that oftentimes we are looking at people in a single test occasion. So somebody comes into the clinic so we can see whether their lung function is impaired. We have no previous measurements for that person. And the other challenge is that, you know, if we measure something like 2.7 liters, then our interpretation, it might be very different if that's a male or a female. We know that both the anatomy of the lungs, the physiology, the shape of the chest wall, the strength of the chest wall muscles, as well as the influence of hormones on both lung function and anatomy, differ between males and females. We know there are significant age-related effects. So during childhood, we have to deal with the fact that children are growing rapidly, and that height and age and periods of rapid growth and development will influence the lung function. You can think during puberty, two children of the same height actually will have quite different measures of lung function depending on whether they're pre or post puberty and whether they've had that maturation of the chest wall and chest wall muscles. And I think most importantly, the taller someone is, the bigger their lungs are. So if we're going to look at the measured values, we need to have some sort of reference to compare those two in order to understand whether this is what we would expect or whether indeed the lung function is impaired. And previous to the GLI equations, the answer in terms of what does 2.7 liters mean, or how do I interpret this result, very much depended. It depended on what country you lived in. It depended on which laboratory you had your lung function measured in. And in some cases, we saw that it also depended on which equipment was used within an individual laboratory. And what we have is that there were hundreds of published reference equations for lung function. So they vary in sample size from 100 people to thousands of people. They might look at all ages. They might look at only children. They might look at only adults. They might look at only a certain subset of the adult population. And so prior to GLI, there was a lot of challenges with standardizing interpretation. And what would happen is that people would have their lung function interpreted in one laboratory, and they would go to another laboratory. Maybe they were referred to a specialist, or they happened to come to the clinic on another day and have their lung function measured on another piece of equipment, and their interpretation would change. And so that was the impetus for developing the Global Lung Function Initiative. When we established in 2008, we brought together a very interdisciplinary and multifactorial team. So we have respiratory physiologists, pulmonologists, respirologists, depending on where you are, epidemiologists and statisticians like me, and manufacturers like Vyaire. And I think that's one of the strengths of the Global Lung Function Initiative Network, is that we've looked at solving a problem from all different stakeholders to make sure that it was relevant and appropriate. The key aim of the GLI is to create all age multi-ethnic reference equations, not just for spirometry, but for all of the lung function tests we use. Our goal is to standardize how we interpret results so that the clinical interpretation, or how lung function is used to diagnose and manage people with respiratory diseases, is not dependent on which reference equation is particularly programmed in a specific piece of equipment. And some of you may be surprised, but I can guarantee you that not a lot of funders want to pay for collection of healthy data. And so GLI is also unique in that it relies on you. It relies on collaborators and people from all over the world to contribute existing data. So we use repositories of large population-based studies like the NHANES study in the US, or several of the large European cohort studies. But we also take data from centers, small data sets where somebody may have measured healthy individuals as a control group for a research study, or we use biological controls from laboratories, and we combine existing normative healthy data in order to be able to characterize normal across the age range. And so as a kind of high-level summary of GLI, in 2012, we published our first set of equations, which were for spirometry. Later, we focused on diffusion capacity, or TLCO. And more recently, in 2021, we published the GLI lung volumes. And we're busy at work, thanks to the support of the European Respiratory Society. We're in the process of doing equations for exhaled nitric oxide. We have amassed a lot of data for impulse oscillometry. Multiple breath washout and cardiopulmonary exercise testing have just kicked off. And so as you can see, while we currently have equations for the 3 main lung function tests that are used, we are looking to expand the scope and continue doing this work for many of the other lung function tests that we use. So I'll take a step back just to talk a little bit about each of the main lung function reference equations, but I just want to highlight that it takes a village. So I have had the absolute privilege of learning from some of the giants in respiratory physiology and working with a very dynamic group of people to produce these equations. So spirometry equations are perhaps our most used equations. They're the most used clinically, but also where a lot of the GLI evidence has come from. So for spirometry, we have equations that are based on just about 80,000 healthy individuals. And so this represents the largest collection of healthy data anywhere in the world. And because we have data from the age of 3 all the way to age 95, we're able to produce these continuous reference equations so that you have a single source that you can use to interpret results across the entire age span. Now you'll notice here that we have reference equations for 4 different ethnic groups. And what you'll notice is that we have these proportional differences. So the patterns of lung growth and development are exactly the same in these groups, but we have these proportional offsets. And I'll spend a little bit of time later on in the talk talking about the challenges of ethnic specific and whether this is really the way we want to move forward. The other task force that we produced was the TLCO reference equations. These are a little bit more challenging. So you can imagine that not as many people collect DLCO or TLCO data. So these equations were based on about 12,000 measurements. And you'll notice right away that in the 20 to 40 age range, we don't have as much data as we do in the other age groups. But I will highlight that in that 20 to 40-year age range, it's actually the largest collection of kind of measurements in that age group compared to any of the other published equations. The other challenge with the TLCO equations is that not everybody performs the measurements the same way. Not every device makes the same assumptions. And so we had to do some initial harmonization of the data. So for instance, although many people use hemoglobin adjusted DLCO to interpret lung function in people with respiratory conditions or with disease, it was very rare for people to collect normative data or healthy data and adjust it for hemoglobin. So all of the reference equations are unadjusted for hemoglobin, and it's important to take that into consideration when you're interpreting the results clinically. We also noticed significant effects of altitude or barometric pressure. And so the equations are based on what we would assume at sea level. So if you happen to be living in a center that is at slight elevation, you will need to apply a correction within your equipment to adjust for that change in barometric pressure in order to use the GLI equations for TLCO. And the other challenge that's less of a user issue and more of a manufacturer issue is that not every piece of equipment adjusts for dead space in the equipment in the same way. And so we produce formulas in order to standardize that. And this is particularly relevant in children and in people with smaller lungs. And then more recently was the lung volumes task force. So again, more challenges because very few people have collected normative data in lung volumes, but we were able to create equations based on about 7,000 measurements in healthy individuals. And a couple things to point out here. So first, we combined data for FRC, at least from helium and nitrogen dilution, as well as plethysmographic measurements of lung volumes. Now, that's not to say that measurements made on different devices or different techniques are interchangeable, but what was remarkable was that when we looked at FRC in healthy individuals, the FRC was constant, or we had the same range of FRC values in healthy individuals, regardless of which piece of equipment is used. And so we have a harmonized reference equation for FRC. But obviously, if you're measuring the outcomes on different devices using different techniques, that needs to be taken into account when looking at the individual values. The other thing I want to point out in this graph right in the middle is that relative to what's been published in the past, there are quite a few differences to those published equations. So if you update to GLI equations at your center, we see that in children, there's a lot of agreement or very little difference between what was been published in a contemporary setting to the GLI equations, whereas in adults, we see quite different offsets. And this depends on which equations you've used in your equipment previously. So this bright yellow line that you see are reference equations that were published in the 1960s. And so obviously the techniques, our assumptions about measurement, they're going to be quite different. And also the older equations were based on much smaller number of observations or number of measurements. And so that's something just to be aware of if you switch to the GLI equations, that there will be a change in how results are interpreted. Now, that being said, there are advantages to using now the GLI suite of equations. And so one thing that we did to check whether the equations are internally consistent is that even though our spirometry, diffusion capacity, and lung volume equations came from different individuals, so different centers, different individual people contributed to the three equations. But when we look at FEV1, then those people that contributed TLCO data, but also had FEV1 measurements, and those that contributed lung volumes, but had FEV1 measurements, we see that those individuals actually match very well to the GLI spirometry equations. And so even though they're kind of heterogeneous and derived from different populations, what we see is that there's actually good consistency between the three suites. And I think a lot of people have been waiting for this full suite of equations to update the equations in their equipment. And in this way, you can use the same set or the GLI set for all of the tests that you're using, and you have a single update as opposed to doing it for each of the different tests. I promised to talk about limitations. So while GLI have been a pretty substantial improvement in terms of the standardization of how we interpret lung function measurements, I think that our efforts have also highlighted some of the assumptions that we make and maybe some of the incorrect assumptions we make when we use reference equations to help us interpret the measured lung function values. And the key thing I want you to remember from today's talk is that there is a distinct difference between a reference standard and a reference. And so in much of clinical medicine, we use a standard, a measure of physiologically ideal values. We look at clinically indicated limits of normal. And when you report the results relative to a standard, you can be more certain that the results outside of that range are physiologically implausible, or that they're not compatible with what we would expect in an ideal health setting. The challenge with lung function is that we only have a reference population. We only collect data, and this is regardless of whether you're using GLI or any other reference equation. We only collect data in an otherwise healthy population. So these are people who are non-smokers and don't have a doctor diagnosis of respiratory disease and don't have respiratory symptoms at the time of test. But we know that the influences of lung function are far more complex. And we know that people's self-reporting of their smoking history or their exposure history, their occupational exposures to potential harmful effects on the lungs are not captured in our reference population. And so oftentimes we use reference equations to say normal versus abnormal. But indeed, all we can really say is that these results are compatible or within the range that we would expect in otherwise healthy individuals, or they're outside of that range. We really shouldn't be using this normal, abnormal label, because the population that we're comparing it to does not represent an ideal lung health. I think it would be next to impossible to find a single population or even individuals within the world that have had no negative exposures to the lungs, because we know that actually there's multi-generational effects that influence our lungs. There's influences and exposures in utero and during childhood that have a profound impact on where our lung function is during adulthood. And one of the kind of reasons why I think GLI has gained a lot of traction despite its limitations is that we've worked together collaboratively, not just within our working group, but with all of the major respiratory societies. And we've worked closely with manufacturers to develop various education and knowledge translation materials. So if you haven't seen in the ERJ Breathe, I think the ERS Breathe journal, we have several overview articles that talk about the GLI equations. We have an ERS learning resource. And if you haven't seen this, we have lots of tools and resources on our website, which is recently updated to look more like a 2020 era website. And for those of you that don't know, we also have our online calculator. So if you haven't installed the equations, or you have a research study that you'd like to have your results interpreted using GLI, we have a fairly user-friendly online calculator that is freely available to use. And for manufacturers and clinical research organizations, pharmaceutical companies, we also have an API, which is a way to program the GLI equations into existing software so that you don't have to do that programming yourself. And then we've also worked very closely with the ELF to develop patient information leaflets, not necessarily about GLI, but about the interpretation and how lung function tests are used from the patient perspective, so that they are informed a little bit more. I was quite surprised when we did a survey of people living with respiratory diseases all around the world. Most people who have their lung function measured don't really know why they're measuring their lung function, what their results mean, or how they should use their results to inform whether they change their behaviors, or how they can have conversations with their practitioners about how to improve their lung health. And so I've kind of already said this, but GLI has become the largest collection of normative data for lung function. We have an open repository such that anyone can continue contributing data to the GLI so that we can have regular updates. We had thought by now we would have enough data to do an update, but we haven't quite collected as much data as we would have liked to. And there's certainly issues in terms of going out and prospectively collecting data in underrepresented populations. So anyone that's interested in working with GLI for this, please do reach out, because we are always looking for new collaborations and ways to support teams to get better and accurate measurements in healthy individuals. And so before I get into lower limit of normal, I just want to highlight why this matters. So I've highlighted that prior to GLI, we had a patchwork of reference equations. And I think that the take-home message is that it does matter for patients. And so this is an example. I've chosen this one because it's published, but when we go and we talk to people in places around the world, we get very similar examples in slightly different scenarios, but we know this is happening quite regularly everywhere. So this is a patient with cystic fibrosis. You can see initially they have their kind of routine measurements, and there's obviously variability in lung function. And so we have somebody that's followed for quite a number of years. They're kind of tracking along in the 80 to 70% predicted. And then in this very first drop, we see a patient with a classic pulmonary exacerbation. So they have symptoms, they have fever, they're coming into hospital, very symptomatic. They get hospitalized, treated with IV antibiotics, and we see this kind of classic return to baseline after the successful treatment of a pulmonary exacerbation. The patient comes back about a month later feeling great. The antibiotics were successful. He's gearing up to go on holiday, and the team measures their lung function, and we see a precipitous drop in FEV1 that's the same magnitude as a classic pulmonary exacerbation. And so the team gets worried. They're telling the patient that they need to cancel their vacation. They're thinking they should readmit them because maybe he's asymptomatic, but there's something happening with the lungs. They're talking about imaging. And then the respiratory physiologist on the team said, wait a minute, let's just have a look at the absolute values. And when you look at this person's measured FEV1 in liters, what we see is that actually there was absolutely no change between the post-hospitalization visit and the 1 month follow-up. If anything, there was an improvement in lung function. And so if we were in an audience, I'd ask you what happened, but many of you know that the only thing that changed in this individual was that they had turned 18 years old. He was going on vacation to celebrate his 18th birthday. In the background of the pulmonary function testing equipment, the equations had changed from pediatric to adult. The person's lung function didn't change at all, but the interpretation did because the reference equations in the background changed. And the fact that they were not seamless, that there was a gap between pediatric and adult, meant that this person could have been subjected to unnecessary CT scans, invasive bronchoscopy, or would have had another hospitalization with all of the consequences and implications of that, not because their lung function changed, but only because of the reference equations in the background. And so I think it's important that we appreciate the assumptions that we make when we interpret lung function, and recognize when we compare results or we get a percent predicted, that we appreciate where that comes from. When you use the GLI equations to interpret this person's lung function, we see that continuity, we see the seamless transition, and the results would have been interpreted as stable and not having that drop. The second area of this talk is to talk about the lower limit of normal. So since 2005, both ATS and ERS have recommended that the 5th and 95th percentiles of the healthy distribution or the healthy population should be used to describe unusually low or unusually high results depending on the lung function test. Now, we use the 5th and 95th percentiles because most often when people are coming into a respiratory lab, when they're referred for lung function testing, they're referred because of some symptomology. Maybe it's dyspnea, maybe they're a smoker, maybe there's some history that has brought them into the pulmonary function lab. If we were doing a population screening like the Healthy Lungs for Life and measuring people without an a priori reason to be in the lab, we would probably use wider limits of normal or lower and higher percentiles respectively. But in the pulmonary function lab, where we are suspecting an a priori reason for having an abnormality in the lung function, we recommend the 5th to the 95th centiles. And Herman mentioned at the beginning, why don't we use percent predicted? Well, I've been doing this long enough to tell you, I understand why percent predicted is so intuitive. It makes sense. It's easy to explain to patients. It's simply a reflection of how far you are from what's predicted for that person. And that makes a lot of sense. And I think that's why it's the most widely used method. The challenge with percent predicted, well, there's two. One is that we assume that 100% predicted represents normal and there's a single value of normal. And in reality, what we know is that for a given height, age, and biological sex, we have a range of values that are actually compatible with health. And so there isn't a single measure that's ideal. And certainly anyone with lung function above 100% predicted doesn't have super normal lungs. They just happen to be on the other side of what the average person's lung function looks like. The other challenge is that we have become very accustomed to using a fixed cutoff to define normal and abnormal. So if I asked you in the room, many of you will be very familiar with saying anyone whose lung function is below 80% has impaired lung function, and those above 80% have normal lung function. And so if we take that example of 80%, so this is the same example I've been telling you about, their predicted lung function is about 78%. Now, intuitively, what we know is that younger people with more reduced lung function have a greater severity of their lung function. But nothing about percent predicted tells us about that severity. It doesn't tell us about those age-related changes. And the work that Philip Quanier did many years ago really nicely showed the age and sex bias in using percent predicted. So 78% predicted for an 18-year-old is actually impaired lung function. That person has lung function well outside what we would expect in healthy individuals at about minus 2.5 Z scores. That same measured lung, or that same percent predicted in an 80-year-old actually represent results that are well within the normal range. And so we would be over-identifying older individuals as having impaired lung function when actually it just reflects the changing physiology of the chest wall and the lungs. And in the younger individual, we might be looking at that as borderline when in fact it is much more reduced than what we would expect in a healthy individual. And so if we ignore this range, if we ignore the age-related range and we use a single cutoff of 80% predicted, we're actually misinforming at both extremes. The other challenge in respiratory medicine is that we use 80% predicted for every outcome for every pulmonary function test. And the reality is that this is not a scientifically robust cutoff. And I'll tell you what I found in digging. So where does 80% predicted come from? Why are we using this for every outcome, every lung function test? Well, if you go back through the literature, we see that 80% predicted comes from historical studies that measured military recruits. So men between the ages of 18 and 30. 80% predicted comes from studies that were conducted only in men. So if female lungs are different in any way, this 80% predicted does not take that into account. 80% predicted comes from the idea that when you measure healthy individuals, you're going to get a distribution of values. You're going to get a normal looking distribution. And 80% predicted represents that 5th and 95th percentile. So the same as ATS recommendations, but from that very narrow range of adults. And what we see is that when we use 80% predicted, we're assuming that the standard deviation is about 10%. In reality, when we look across all ages, when we look in large samples of healthy individuals from all over the world, and we look at different lung function tests, we see that that 10%, this horizontal line, really only applies to men between the ages of 18 and 30. And even then, it's probably an underestimate. When you look at children, when you look at older individuals, we see that the range of normal is much wider, which means that the lower limit of normal, or what's compatible with health, actually is much wider than 80%. So for spirometry, we're looking at in children and older adults, a range of normal that's between 70 and 130% predicted. And for DLCO or TLCO, or many of the lung volume measurements, that variability is high as 20%. So the normal range is actually between 60 and 140% predicted, and in some cases, even wider than that. And if we fail to ignore the wide range of heterogeneity of lung function between different people, we could be incorrectly labeling people as having abnormalities when they do not, and missing important early deficits or early impairments that could be amenable to treatments. Now, we talk about Z-scores. I don't expect anyone to use Z-scores or explain Z-scores to their patients, and that's why we've developed this pictogram. So many of you who have updated your equipment or software in the last 5 years will notice that you now have, in addition to the numerical output of percent predicted, lower limit of normal, we have these visual representations. Oftentimes, the normal range, which is white here, is a green circle or a green area. And then the farther away you get from that normal range, the indication goes from yellow to red. And I think intuitively, this is much easier to explain to patients. The farther you are away from what we would expect in a healthy individual, the more we can be confident that your results are not indicative of what we would expect in health. The closer you are to that normal range, or if you're in this orange zone or the zone of uncertainty, that's where we may want to do additional tests. We may want to go and get imaging or a more comprehensive suite of pulmonary function tests. And I think it's moving away from this dichotomy of normal and abnormal to looking at how far someone is for what we would expect in health, looking at an individual's measurement repeatedly over time, and using lung function in addition to all the other information that you have, as opposed to just making binary classifications based on 80% predicted. Now, I promised I would talk about race and ethnicity because I think this has always been something that has challenged GLI. And in recent years, especially with a lot of recognition, particularly in North America, that race and ethnicity are social constructs, they're not biological constructs. And if we're using them to interpret biological measures and make clinical decisions, we may be systematically and unconsciously making biased decisions and discriminating against minority populations. And so as a background, we know that people living in different parts of the world have differences in their lung function. Even people living within the same country, within the same region of a country, there's a lot of variability between individuals. I always say people come in all kinds of shapes and sizes, and so do their lungs. In some cases, we know why there's differences between different populations or why there's differences between different subgroups. In other cases, we've made a lot of assumptions. So I'll first highlight In GLI, we have 4 ethnic groups. We have the white European, or what was labeled as Caucasian, African American, which predominantly comes from people measured in the United States. And then we have Southeast Asian and Northeast Asian. Every week, I get lots of emails. What do I do with this group? How do I interpret lung function in this country? And the reality is that GLI is not globally representative. We have hardly any data from the African subcontinent. We have no data from India. We have no data, or very limited data, from Latin America. And so while we say they're ethnic specific, or we have these ethnic groups represented, we have a significant challenge because many people living around the world are not represented within the GLI equations. We have people with genetic admixture who might have parents from different ethnic groups, and we don't know what to do with those subsets or those populations. Now, some of the reasons why we think we need ethnic specific equations is because there's been some work looking at genetic admixture. We're looking at people with a greater proportion of African ancestry in their genes show to have, on average, lower lung function than people with more European ancestry in their genetic admixture. And these results have been replicated in a couple of studies now. So there certainly is a genetic component, but it's a very small component. And the more we know about genetic testing, the fact that in many of these studies, they have been done predominantly in people of European ancestry. And again, we don't have good global studies. We're learning that the contribution of genetics, while important, may not be as big as we once assumed. The other reason that we've considered ethnic specific reference equations is that when we look at differences in body proportions, so leg length versus chest size, we see that height or standing height is actually really poor proxy for chest size. And so what happens is that people of different ethnic backgrounds or people with different genetic ancestries, we actually see that the proportion of sitting height to standing height, or their chest size relative to their standing height, differs. And this work by Janet Stokes' team in London was able to show that the differences we see in FEV1 and FVC is actually proportional to the differences we see in the sitting height and standing height ratio. The challenge is that on a group level, we see these averages. But if you look at the range of sitting height to standing height ratios, there are many people of Black and South Asian ancestry that have very similar body proportions to the white European population, and vice versa. The other challenge is that we haven't done a very good job of measuring the social determinants of health. So while, yes, sitting height and standing height and genetic differences exist, many of the studies that we've done have completely ignored the fact that the social determinants of health, the effects of air quality, the effects of early nutrition, all have a significant impact on our lung function. And this is work by Sam Sanapa's group looking at South Asian children in London, and the same ethnic group living in India, and she's looked at urban, semi-urban, and rural areas, and we see this very clear socioeconomic gradient. And so it's not as simple as saying that everyone comes from Asia follows the Asian reference equations, or everyone that comes from Africa follows the African American reference equations. There's so much heterogeneity in how the lungs grow and develop and what the lungs look like in different populations, that truthfully, using simply standing height, age, and sex probably isn't a very good indication of how big your lungs should be. And it ignores all of those unmeasured residual confounding effects on lung health, such as air pollution and early nutrition. And so thinking about the influences of our environment, our genetics, our social determinants of health, the factors that influence our lung growth and development and lungs in adulthood are far more complex than we've come to recognize. And although GLI or any reference equation helps us to standardize, to have a single way of interpreting results, again, labeling people as normal or abnormal without considering and including these very structural determinants is probably missing early impairments of lung function, and we're potentially misclassifying people as normal when in fact they may have reduced or impaired lung function that would benefit from treatment or intervention. And so in summary, I think the key advantages of the GLI is that it is truly a global and altruistic effort. It has helped to standardize and improve the diagnosis and management of lung disease. It's the first time we have all age reference equations that look at childhood and adolescence in a robust and methodologically valid way. We finally have international standardization. And importantly, we incorporate this age-related variability to move away from 80% predicted to have a more accurate age-dependent limit of normal. And it provides patients with a consistent record of their health. But I'd be remiss to say that the GLI are the ultimate solution. If I've learned anything over the last 20 years, is that we've made improvements and identified a whole area of work to be done, and particularly around what we label as healthy, how we incorporate lung function into clinical decision making, and more relevant in the recent era is if we are unintentionally normalizing disparities in lung health around the world and underestimating the true impact and the true burden of lung disease by not properly accounting for what your lungs should be as opposed to what the lungs are in an otherwise healthy group. And I had the benefit of learning from Philip Quanier, who's the godfather of reference equations and a giant in respiratory physiology. And the one thing that Philip always told me was that we need to treat the patients. Lung function measurements, reference equations, percent predicted Z scores, whatever you use, they all help inform your decisions. But most importantly is the patient sitting in front of you and understanding what the measurement, what the result means for them, as opposed to making decisions based on the numbers alone. And so I'll end there and welcome any questions from the audience. I see we've got a couple in the Q&A.
Thank you, Sonia, for this very nice and clear presentation. Yes, you can also see the questions already from the chat box, and I will read them for you. We already have 7. We try to manage this in this 15 minutes. Hopefully you can do this. First of all, what is the influence of a decrease in length? And I translated a little bit. I see the question is more, how precise should we measure change in height regarding to the influence on the reference values?
Absolutely. So I think as I mentioned, height, I think, is a very poor proxy for chest size. We know that people living at altitude have differential growth of their chest size relative to their limbs. We know that people who have poor nutrition in early life will again have different body proportions. And so absolutely we have to measure height. It's such an important, like obviously the taller someone is, the bigger their lungs are going to be. But I don't think it's the only answer. The other challenge is that oftentimes, I'm not naming any names, but we don't measure height in the lab. Somebody comes in, how tall are you? And then they give us a number. That number is often misrepresented. So you'd be surprised. Men say that they're taller than they usually are, and women say that they're lighter than they usually are. And so it's important to measure height because even though it's a poor proxy, if we don't get a proper measurement, we can see differences as big as 10% predicted only because the wrong height was entered into the equipment. The other thing I'll add to there is that many places don't calibrate their stadiometers, or they move them. And so, you know, I have 2 different stadiometers in 2 different parts of the lab. And sometimes I have kids that shrink. So they come one week, they're measured in one room. Then they come the next month, they're measured in another room, and they are actually shorter. And I think that having precise measurements of height is a bare minimum to at least address some of these issues.
Okay, thank you. In addition to this, what about the shoes? Maybe in relation to men and women?
Yeah, so, you know, again, so it's a challenge because ideally they should be measured without their shoes on, because shoes, depending on the gender, can be very kind of a big influence. But, you know, then I talk to people who actually do measurements and they're like, well, when a 70-year-old woman comes in with her walker and you need her to take off her shoes and you need to, it impacts the flow in the lab it may, inconvenience the patient. And so it's not easy. And I know it's easy for me to say, measure them without their shoes on. But in reality, I think we need to think about the full picture in terms of how much time we're giving patients in the lab, the flow throughout the lab, and how we do this.
Okay, thank you for your honest answer. Why does GLI, the spirometry, doesn't have peak flow measurements or peak flow references? And also from a company now being here for a few years, it was always the question, why don't the flow volume shows on the report when you understand the question?
I know this question very well. So I will start with the future. So we are collecting it now, and we are asking people to contribute. So this is something that we've recognized as a limitation. The simple answer is that when we brought data together, we did not have enough people who contributed PEF measurements. And so if we created an equation for peak expiratory flow, it would have been on a very limited subset. The challenges to peak expiratory flow, really people use it as a guide to help with the flow volume curve to know about the effort. In terms of the clinical value, we don't really use peak flow as much as we do the other parameters. So, in terms of some of the rationale 10 years ago when we did this, we didn't see it as a kind of something that we needed to kind of put in there. In hindsight, I think it's caused a lot of problems, and we are working on solving that in the next iteration.
Yes, especially showing the flow volume curve, but now I'm speaking for myself, I think it's important. How to deal with ethnicity differences within GLI, within the question from Hanneke is about TLCO, but the same question could be for the absolute lung volumes.
Yeah, these are excellent questions. Wow. So the answer, the honest answer, is that nobody has done a good job of measuring lung function with TLCO and lung volumes in non-white European populations. So even if you go through the literature, if there's any studies, they're based on 20 African Americans, or they're based on very small samples. And we've really done a terrible job of, one, ensuring that measurements of TLCO and lung volumes are available in an equitable way around the world. But even then, the data available in healthy individuals is very limited. So we've got a couple data sets in Asia, but again, from a GLI perspective, we got very limited data. So we couldn't make assumptions or interpretations about how lung function would differ in different parts of the world. But if the same factors contribute to these measurements, like your standing height and how standing height is a proxy for your chest size, then I think we would come up with the same answers in terms of the offsets. And so what I would say is we should be cautious about applying results. I think we should kind of think about a wider zone of uncertainty. And the other thing is, if somebody comes into your lab, regardless of what their ethnic background is, if they're well within the normal range, it doesn't matter what reference equation you use, they are in that normal range. If they are well outside the normal range, they're in the -4, -3 Z scores, it won't matter what reference equation you use, they have impaired lung function. The challenge is in that -2, that zone of uncertainty. And so if a patient comes in and they have symptomology, they're a smoker, they have dyspnea, they have all kinds of obvious factors that would impede their lung function, and they're in that zone of uncertainty, that's a very different interpretation than if a Usain Bolt marathon runner comes in perfectly healthy and they are in that zone of uncertainty. So I think we have to kind of treat the patients, not the numbers, and use these measurements and use the standardized values to inform decisions, but not try to put people into boxes, not try to label people according to their ethnic group, because I think more and more now we're coming to recognize that there's more heterogeneity within populations than there is between populations.
Okay, thank you. Next question. I guess I know your answer. I don't know. Should I use more Polgar references for spirometry and lung volume testing?
So my academic conflict here is no. So depending on the age range that you're looking at, Polgar equations, if I recall, are actually based on mathematical averages of different equations. They're not based on the data. And if my memory serves me right, similarly, Morris is based on a very small number. So I know people have become used to using the equations that are in their equipment. If you know what equations are in your equipment, then you are part of the 10% of people who actually have bothered to look. And so, you know, I think it's important to look back at those papers, look at how the equations were derived, and then compare that to some of the contemporary equations that exist. I have a bias. I think you should use GLI, but it's really about finding what's right for your patient population.
But also from your previous answer, if you are really normal, it doesn't matter which, and if you're really outside normal, and then, so I think they are connected to two answers. Mm-hmm. Another question, again from Hanneke van Helvoort, how to deal with the difference in severity grades based on Z-scores of the GLI, because they seems not to very much relate to the percentage of predicted from GOLD.
Mm-hmm. Okay, so I'm going to another plug. So ATS and ERS have just published the new pulmonary function interpretation standard. So I would recommend that you have a look at that document. But what I will say is when we look at the physiology of the lung, when we're using reference equations, remember we're describing a reference population. And so the severity scores according to Z scores for GLI are basically just saying this is the distribution of values. We anchor it to survival in terms of defining that severity, but it doesn't align with GOLD. And the reason for that is, one, GOLD focuses a lot more on percent predicted, but we have to think about it again, why is that person in that test? So when you're looking at an adult smoking history population in the 60 to 70 year age range, then those GOLD percent predicted criteria have been linked to the clinical outcomes in COPD in that particular age range. What we've done a terrible job of in respiratory medicine is we've taken those GOLD criteria for severity and we've applied it to kids, we've applied it to IPF, we've applied it to every disease and said this is how we define severity. So what we hope is that people will start using Z scores. We'll start using these limits based on how far you are from normal, not percent predicted, which we know is age biased. And then we'll actually start linking it to clinically relevant outcomes. So in COPD, what are the factors that lead to emphysema, or what are the factors that lead to dyspnea in COPD? In asthma, what are the severity cut points that are associated with poorly controlled asthma? I think we need to move away from one size fits all, 80% predicted, or these limits of severity, and really start thinking about in a specific patient population linked to clinically relevant outcomes, how can we use the physiology that we're measuring to inform what to do with an individual patient?
Yeah, and this was also one part of the question, that change of therapy based on the severity. And I think you mentioned it now already several times, and also saying what Philip Quanier said, treat this patient based on a lot of things and not only spirometry values or Z scores or whatever, but Z scores are important. What would be considered as a significant bronchodilator reversibility in Z score?
Mm-hmm. Okay. I don't have the answer to that, but we have in the interpretation standard, we have looked at redefining bronchodilator response to address the age and sex bias. What we've anchored it to now is a measure of severity. So it's actually looking at the change relative to what is predicted as opposed to the relative change according to baseline. So again, I'll maybe Herman, I can send you the link to the new interpretation document, and we go into details. It's not, I will come back to why do we measure bronchodilator response, and is it actually, think about why you're using it and what you're using it to differentiate. But there certainly is an age and sex bias in what we've done in the past. I don't know if our current recommendation is the ideal or the absolute answer, but it's a step towards that.
Yeah, and if you send me the link, I think we can share it with the participants.
Excellent.
A small question from my own side, although there is, because it's all about doing an interpretation on one measurement. And I think in the PFT lab, measurement change over time is much more important. I dare to say now to you, is GLI also thinking about like what is a clinical meaningful change in set scores or whatever? That's always my...
Absolutely. So we have some solutions. So you're absolutely right. Even if somebody is there for a diagnostic reason, it's far more informative to get more than one measurement. We also, spirometry is an effort dependent test. So if you can get the same result on 2 separate test occasions, that tells you more than, potentially a low result in one test. The challenge, so there's 2 challenges. One, getting repeated measurements in healthy individuals. We have a lot of data in children, and we have a lot of data from occupational medicine, where cohorts of people working in different settings have been measured. But we don't have a lot of healthy individuals that volunteer to come for repeated measurements. That being said, we do have out now what is a clinically meaningful change based on Z scores for kids. It's called a conditional Z score. It takes into account where somebody starts. It takes into account their age, because again, the older children get, the more reproducible the results get. And it also takes into account the time interval between measurements. So if you measure your lung function a month apart, it's going to be more similar than if you measure it a year apart. So we do have that. There's an algorithm. It's for manufacturers. It'll be very easy to implement. So at least it gives us an indication in children how far away someone is from normal. And in adults, we've actually changed our thinking a bit to start thinking about how far someone is from the bottom. So what is a measure of lung function that's compatible with life? And if you're progressing towards that limit of kind of what's compatible with life, you have significant deterioration. If you're tracking, and that's why, again, looking at absolute measures in an adult population, someone's tracking and they're kind of within their normal variability, that's more indicative of stability versus if you see somebody starting to drop off. And so we have some ideas for how to do it better, but really we need to go out and verify these new approaches and make sure that they're clinically useful.
Next question, very interesting, because it took me already a lot of work the last weeks, and so I'm happy you can answer this. What about, because I recognize this, that we get a lot of questions that people want to have reference values outside or above the upper limit of age ranges. How should our end customers deal with this? And you see, would it be an idea to I call it frozen the upper limit and just copy this above this? Ideally, you make a new publication and then we from Fire Medical can put it officially in, and now we have to help, or I don't know. Or should the other solution is that people put another author which published above this age range, and then you are as also long in this field that people want to have values in a certain age range.
So I'm gonna go from the top. So stitching and switching equations from another equation, that is the least palatable option. So I think that's a challenge because, again, usually they're made up of very small number of people over the age of 80 or 90. So I would not bring in a new equation. We also have some evidence not to extrapolate, so not to extend the predicted line for older individuals. It's also really hard to do that in GLI because of the splines. So I think the most practical solution is to take the upper range. So let's say that's 80 or 95, And then in your report, the results are interpreted against somebody who is 80 years old, right? So again, treating the patient, why is that 90-year-old there? What are we trying to identify? Is it to identify a pattern of physiology, in which case, the flow volume curve is going to tell you a lot? Is spirometry the right test for a 95-year-old? When we move to lung volumes and stuff, again, thinking about what we're trying to do with the lung function test in order to inform those measurements. But from a practical, what does Herman do at your device? I would say take the last valid age range and then ensure that that's stated on the report.
It's not really my advice. We try to be practical and we hope to get the solution for you. And this is what we do with this webinar. In regard to age and height, should we take the initial height or the current height?
So you're meaning like in older adults when they start to shrink a little bit, I'm guessing.
Yeah, it's not my question, but I can imagine you have a height measured on the first measurement and the second measurement, you have another height.
Yeah. So in kids, use the measured height on each test occasion because kids grow, or at least my kids are growing like weeds. So when we get to adults, I would say that ideally we would want to have a couple consistent measurements of their height. So if you have somebody who's kind of in the clinic every 3 months, in the clinic every year, and you have a consistent measurement of their height, then there's more reason to use their initial height rather than continuing to measure it. If you have somebody who's kind of aging and shrinking, I think we should try to use their initial height, because what we find is that because they're shrinking, they're not actually shrinking. It's just their body shape is changing. Their lungs, the shape of their chest wall shouldn't. So there's no easy answer because it depends on who the patient is and what their particular circumstances.
Due to the time, I take the last one. I just pick last one because I think there are a lot of just things. And if we go on, and this is good, people don't stop asking questions, and they should not. It's about the question from Norway. This will be the last one. It happens several times in Norway that the customer have patients over 95. Maybe Norwegians are too healthy, of course, with the kind of, I have changed back to ECCS when they are above 95. And I think you already answered this question.
Yeah, I would do, and I think that someone has put in the thing, I would take their age at 95. And I think there was another comment about, there's very few data in the GLI even between 90 and 95. And so again, if somebody in the healthy Norwegian population, if they're coming in, I think we can take what the last known measurement and then talk about where they fit. I think the challenge with changing to ECCS is that then, when you're tracking that person over time, you don't know if that change after 95 is because you switched to a different equation or whether the person has changed. And then also ECSS, again, it's based on men only. So even though they had 95-year-olds, I think there's a lot of limitations with that equation. And we've repeatedly shown, particularly in European populations, that they don't necessarily reflect contemporary lung health.
Yeah, and people, sorry for this, I always have one extra question. And the other additional thing I want to say to this frozen one, I now know, because working with the predicted utility we have, people can froze it to whatever they want, to the upper limit of age range which are published, and you can go on to 120. So there is this functionality. So this is, and I think this is the clinical important one. What if a pediatric oncology patient has something above 130% or 120% of predicted, and it goes down with 30%, but still stays in a normal range? As a last very clinical important question.
Thank you, Mike, for that question. That is like that. I think that's the take home of all of this. Yeah. So one, it doesn't matter if they're in the normal range. If an individual is dropping and dropping by more than 30%, that probably is indicative of something that's not so good. But this is a perfect example of that conditional change score that we developed, where it doesn't matter whether you're in the normal range. It looks at comparing the change for that individual relative to where they started from. So somebody who starts really high and is dropping by more than 30% would be flagged as a significant deterioration outside of what you would expect from the normal variability. And I think we have to start looking at how individuals are changing over time. On this normal, abnormal, it's only useful if you have a single person measured on one test occasion to give you an indication of where they are relative to normal. Once they're coming in for repeated measurements and you have an intervention in the middle, tracking the individual is so much more important than whether or not they're in the normal range. Same with CF, same with, a lot of these conditions where we're tracking people over time. I think so much more important to look at changes.
Okay, thank you. Thank you, Sanja, for this excellent presentation and all answering the questions. Apologize for my side that again, I took a little bit more than 5 minutes of extra time. But I really hope we can do a topic like this within a year again, because it is very important, this interpretation of RDX respiratory diagnostics. I close now this webinar. Thank you for your attention and hope to see you in the next webinar we will organize. Thank you. Bye to all of you. Bye and thank you.